Videos. These are non-conventional ways of taking care of the baby. Okay, non-conventional ways. Rarely would you do them, but they all can be done depending on what is wrong with the baby. Okay? So we are going to go through them. Okay, so the first one is surfactant replacement therapy. Now, like I said before, any baby that is born less than 35 weeks of gestation will likely develop RDS because the mature type of surfactant doesn't begin to appear until the 35th week of gestation. Okay? So now if you're taking care of a baby on the ventilator and they're premature, okay, and you're having problem increasing their compliance as well as their oxygenation, and you've used a PEEP of 8, okay, you may want to consider giving them surfactants because surfactant will improve their lung compliance and enable you to use lower PIP, okay, which would then cause the baby to oxygenate better and ventilate better. Okay? So, surfactant is produced by the alveolar type 2 cells. Okay? It is present in the inside surface of the alveolus. The inside surface of the alveolus. And what it does is it helps to overcome surface tension. We also call that alveolar surface forces. Okay, this is the force that is inside our lungs that tends to cause the alveoli to collapse at the end of exhalation. So if it wasn't for the presence of surfactants inside our lungs, each time that we exhale, the alveolus will completely collapse, okay, making it very difficult for us to open them back up in the next inspiration. So it increases lung compliance. These are the components of surfactants. The predominant components of surfactant is phospholipids. Okay, phospholipids. Now, if you remember the phosphatidylcholine, the PC. The PC is the immature type of surfactant. That one usually begins to appear at the 24th week of gestation. Okay? That PC, we also call it lecithin. That's another name for it. Lecithin. That's how we got the LS ratio. And then we have the PG. Phosphatidylglycerol. That is the mature type of surfactants that babies start forming beginning from the 35th week of gestation. And that one will fight off surface tension really well. So if they have it and they're born, they're not likely to develop a respiratory distress. But it contains lipids, okay, as well as proteins. How do we administer surfactants? The most effective way of doing that is directly instilling it into the lungs via the ET tube. You just pour it down the ET tube. In some cases, surfactant can actually be aerosolized, but it doesn't work very well that way. So the most effective way is instilling it down the ET tube. Okay? So number dose is 2 to 3 milliliter per kg. So usually you draw it up according to the baby's weight, and then you divide it into several portions. And then you're gonna pour it down the ET tube in different body positions. Okay? In different body positions. Indications for surfactants. Well, we have prophylactic administration, which is when you administer the surfactant to prevent the onset of respiratory distress. So this would be on infants that are less than 32 weeks of gestation. The baby is less than 1,300 grams at birth. And LH ratio is less than 2 to 1. Now, normal LH ratio is 2 to 1, less than 10 to sphingomyelin. Okay? And then absence of PG, which is the mature type of surfactant. All of these factors here will predispose the baby to developing respiratory distress. So we want to go ahead and give them surfactants. And then we have the therapeutic administration. This is when the baby develops signs of respiratory distress due to RDS, okay, respiratory distress syndrome. Maybe grunting, nasal flaring, and what is the other one? Grunting.
Retractions.
Thank you, retractions, yeah. Retractions. All those things are signs. And then we want to give them survivors. These are the different types of surfactants. They all will do the same thing. They all will increase lung compliance, but the Azosulf is synthetic surfactants. Azosulf is synthetic, it's manufactured. And then the other three are from animals. Sulfenta, Infasulf, and Corosulf. It's just a question of which one the doctor wants to use, but all of them will increase lung compliance. Advantages and disadvantages of surfactants. Reduces severity of RDS, pulmonary air leaks, and development of BPD. Now remember BPD, bronchopleural dysplasia, that is the condition that the babies get after they are treated for RDS. So the treatment for RDS is the cause of BPD, okay? So now if we can give the babies surfactants, then that will enable us to ventilate the baby with lower pressures and the FiO2. Okay, because what actually causes the BPD is when we use high pressures and high FiO2 in treating the RDS. Disadvantages can cause bradycardia in the baby. It can cause oxygen desaturation. That's one thing with compliance. Anytime you overstretch the lungs, compliance will fall as well as oxygenation. Okay? If you stretch the lungs, compliance falls as well as oxygenation. So we have to be very careful that we're not overdoing the surfactants. You can have a ET tube reflux. Sometimes it will come back up with the ET tube. Okay? Monitor infants' oxygenation and lung compliance during surfactant therapy, and that is true. Okay, now let's say that now a baby is using a pressure of 30 to ventilate. Okay? And then you decided to give them surfactants. Once their compliance improves, you're going to find out that they're going to start getting huge tidal volume because of increasing compliance. So you have to be ready to be able to decrease your PIP so that you're not causing barotrauma in the baby. Okay? The next non-conventional way is high-frequency ventilation. It's a special type of ventilator. It's a type of ventilator. Now, when you go to NICU for a rotation, you may see a baby that is using high-frequency ventilation. It's not a conventional ventilator. It's a little different. And, I mean, these type of ventilator can be used in the adult, but mainly, okay, we use it for children, okay, in the NICU. So normally what happens is that during conventional ventilation, you must always exceed dead space before you can have ventilation, according to that formula there. The other volume must exceed dead space before you can say that you're ventilating. So, but that's not the case with unconventional way of ventilating, like the high frequency ventilation. You don't really have to exceed the dead space. The other one can be equal to dead space, okay? So what matters with the non-frequency, high-frequency ventilation is the amount of respiratory rate, okay? Usually you have low tidal volume and high respiratory rate, okay? So characteristics of high-frequency ventilation, the respiratory rate there is always greater than 150 per minute, and tidal volume is very, very low. Yeah, because the tidal volume is very low, there is always a very low mean airway pressure when you're using the high frequency ventilation. As a result of that, babies are not always, predisposed to developing barotrauma. Okay, because the mean airway pressure is very low. High frequency ventilation is expressed, high frequency is expressed in hertz. So now see now 1 hertz is 60 cycles. So in other words, instead of saying, the baby is on a respiratory rate of 60, we say that the baby is on 1 hertz. Okay? Because if the baby is on 2 hertz, it will be 120 respiratory rate. So instead of saying baby has a respiratory rate of 120, you're going to say that they're on 2 hertz. Okay? Now, on that ventilator, there's 2 major control knobs, actually. That's why there is one they call the amplitude. And the amplitude controls ventilation. It controls the level of CO2. Okay? So when you are increasing your amplitude, you are actually increasing your delta P. Like on the regular ventilator, we have PIP, and then we have PEEP. Let's say that I have a PIP of 20 and PEEP of 5, my delta P will be 15. So the delta P is actually what is increasing the tidal volume. So that kind of stuff. So if you increase the amplitude on the high frequency ventilation ventilator, you are increasing the delta P. Therefore, you're going to get more tidal volume. Okay? So if a baby is on a high frequency ventilator and they have high CO2, the way that you're going to treat that is to increase your amplitude. Because increasing the amplitude increases the tidal volume and blows off more CO2. Okay? And then they have another knob called the mean airway pressure knob, mean airway pressure. Now, the mean airway pressure knob controls oxygenation. Okay? If the baby has low PaO2 and you want to increase it, you're going to increase the mean airway pressure. You turn up that knob. If the baby has too much oxygen and you want to decrease it, you reduce the mean airway pressure. So those two are the main control knobs on the high frequency ventilator, to adjust your oxygenation and to adjust your ventilation. It goes very fast, okay? The baby's chest vibrates like that. Okay, instead of just rise and fall, it's more like vibration because the respiratory rate is very high. Okay? Any questions about that? So please remember that, especially on the board exam. If it's high CO2 there on a high frequency ventilator, you increase the amplitude. If you have respiratory acidosis. If you have respiratory alkalosis, you decrease the amplitude because that gives you lower tidal volume. If you have poor oxygenation, you want to increase the PaO2, you increase the mean airway pressure. If you have too much oxygen, you decrease the mean airway pressure. That's all you really have to know. Okay? Indications for high frequency ventilation. Conventional ventilation has failed at a neonate that has any of the following. They have respiratory distress syndrome, and we have been using conventional ventilator like the ones that we have in the lab. But the baby is not doing well, we can go to high frequency ventilation. The baby has pulmonary air leaks, okay, pretty much like pneumothorax. Okay, we can use that to ventilate them. Because anytime they have pneumothorax, their interthoracic pressure increases, and then if you're using conventional ventilator to do it, their PAP will go through the roof because of all the pressure already there inside the lungs. They have persistent pulmonary hypertension in the newborn. Okay, the pulmonary vessels are constricted. Therefore, the pressure there inside the lungs will already be really high. So we want to use lower tidal volume and high respiratory rate. They have diaphragmatic hernia. Remember, diaphragmatic hernia is where all the stomach contents, will go into the chest, okay, compressing the lungs. While the lungs are being compressed, we cannot use conventional ventilator because the tidal volume generated may be too high to cause barotrauma. So we like to use high-frequency ventilator. Bronchopulmonary fistula. This is where a little hole. Fistula is just a little hole between the lungs and the pleural space. Okay, air is leaking out from the lungs into the pleural space. We use that. Okay. All right. Any questions about that? Like I said now, this can be used on an adult patient. Like one of the questions that you may see on the exam is, a patient is undergoing bronchoscopy, okay? Which of the following type of ventilators will be best? Well, high frequency will be good because it doesn't have a lot of tidal volume. Okay? Because once you go down with the bronchoscope, you create airway resistance plus the tidal volume that is coming in from the ventilator, conventional ventilator, so that will make the PAP go through the roof. But if you're using high frequency ventilator, well, you don't have a whole lot of tidal volume. But do we really actually do that in real life? Not really. You're not going to see any doctor that is trying to bring somebody who is on the ventilator and ask for the high frequency ventilator. But it is true that if you use a high frequency ventilator, then the risk of barotrauma will be low. Okay? Any questions about that? And another thing, remember that a baby has bronchopulmonary fistula. What would be the best type of ventilator to ventilate them with? Remember, high frequency ventilator. Okay? We have 4 types. Okay? And they are divided into 4 types based on the amount of respiratory rate that they can deliver. So we have the first one is high frequency positive pressure ventilation. Now, this is where you are using like the conventional ventilator that we have in there. You can go up to like a rate of 150 on those ventilators in there, okay? You can go as high as 150. So if the baby is on one of those ventilators and their respiratory rate is 60 or more, up to 150, basically you're doing high frequency ventilation. Okay, so we'll call that high frequency positive pressure ventilation. Now this is the only type of mode on the high frequency ventilation in which tidal volume has to exceed the space. This is the only one, okay? Tidal volume has to exceed the space on the high frequency positive pressure ventilation. The rest of them, tidal volume does not have to exceed the space for ventilation to take place. And then the next one is high frequency flow interruption. Ventilation. Okay, so this one here can provide up to 15 hertz. So if you multiply 15 by 60, you get like, let me do the math here. That's 30, that's like 700. So instead of saying that the baby has a respiratory rate of 700, you're going to say that they are on 15 hertz. Okay? It goes very, 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 very fast. Okay? And then we have high frequency jet ventilation. That one is most commonly used. High frequency jet ventilation. And that one can provide up to 4 to 11 hertz. And then we have the high frequency oscillatory ventilation. That one is very common too. The last two are very commonly used. And the high frequency oscillatory ventilation can provide up to 8 to 30 hertz. Okay? Hazards, air trapping, hyperinflation. Well, you know, I can understand air trapping because it's going very fast, like that. Okay. A lot of air trapping is involved. Obstruction of airway due to secretions. What actually causes the secretions to come out of the lungs is the expiratory flow. That's why we tell patients to take a deep breath and cough. They generate a high expiratory flow to move their secretions out. But now, since the tidal volume is very low with high frequency ventilation, okay, babies tend to retain a lot of secretions as a result of that. They get hypertension, they get necrotizing tracheobronchitis. They have a lot of inflammation in their bronchus. Okay? Adequacy of ventilation is measured by chest vibration in lieu of chest rise and fall. Yeah, conventional ventilator will look at chest rise and fall, which tells us the magnitude of the tidal volume that the patient is breathing in. Okay, but on the high frequency ventilation mode, what we look is the intensity of vibration, the baby's chest vibrating. The more vibration that you have, okay, the more the baby is ventilating. The less vibration that you have, the less the baby is ventilating. Okay. So while the baby is on that ventilator, a decrease in chest wall vibration with increase in CO2 and no decrease in PaO2 will indicate some kind of obstruction or malposition of the ET tube. Okay? That's an increase in CO2, okay? But there is no change in PaO2. That would mean some kind of obstruction or malposition of the ET tube. But now, if there is a decrease in chest vibration and there's increase in CO2 with decrease in PaO2, then you would have to suspect a decrease in lung compliance or pneumothorax. Okay? Or pneumothorax. Any questions about that? All right, so the next thing is extracorporeal life support. Usually they call it the ECMO. You can also call it extracorporeal membrane oxygen. Okay, extracorporeal membrane oxygen. You call it extracorporeal life support. Basically, this is a way of oxygenating the baby's blood outside the body. That's all it does. You're going to draw the baby's blood out of their body and then run it through an artificial oxygenator and then put it back into the baby. Just like, I call it dialysis of the lungs. Because in dialysis, what we're doing is we draw the blood out of the body, we run it through an artificial kidney, and then we run it back into the patient's body. So this one is you're drawing it out from the baby's body, you're running it through an artificial oxygenator to oxygenate the blood outside the body, and then you're running it back into the baby's body. That's what ECMO is. Now this is the socket here. So now you can clearly see here where the blood is coming out. Okay, they do a lot of things to it. They add heparin to the blood so that the blood doesn't clot outside the body. Okay? It goes through the pump, and then it goes through, here is the membrane oxygenator, here is the artificial oxygenator, artificial lung, whatever you want to call it. Run the blood through it, okay? It goes through here, then we're going to warm it back up because it's been outside the body, and then we'll run it back into the baby. Okay? Now, this is, a lot of hospitals are beginning to do this now. And if I'm not mistaken, I think Presbyterian has one now. Okay? Okay, there are two types of ECMO. Okay? Basically, where you're going to draw the blood from and where you're going to return the blood to. Okay? The first one is called the veno-arterial ECMO. Veno-arterial. Okay, in the veno-arterial, blood is drawn from the right atrium to the internal jugular vein. It is then run through the artificial oxygenator and then return to the aortic arch. If I spell that out, aortic arch. Through the carotid artery. So let me say that one more time. Did I spell that right? Aortic? Yeah. Okay, so in the veno-arterial, blood is drawn from the right atrium through the internal jugular vein. It is then run through the artificial oxygenator and return directly to the aortic arch or the aorta through the carotid artery. So that's why it's called the veno-arterial. Okay? Now that one seems to be the best because it supports cardiac output. The blood is being returned to the artery, the biggest artery in the body, and then it can flow all over the body. So it supports cardiac output. That's the one of the great advantages of the veno-arterial. The next one is the veno-venous. On this one here, blood is drawn from the right atrium through the internal jugular vein, and then run through the oxygenator, and then return back to the right atrium through the femoral vein. So it's like you're taking it from the vein and then you're returning to the vein. So that's why they call it the veno-venous. So blood is drawn from the right atrium through the internal jugular vein. It's then run through the oxygenator and returned back to the right atrium through the femoral vein. This one here does not support cardiac output, okay, because we're putting the blood back inside the vein. It does not support cardiac output. Any questions? Well, we don't just put everybody on ECMO. You would have tried everything else to try to oxygenate the baby, but the baby fails to oxygenate before you can use ECMO. Okay, so as a result of that, we have indications for it. You have to qualify to receive ECMO. Okay? So one of the things that we look at before a baby can qualify to be an ECMO is the A-to-A gradient. A-to-A gradient. Now, as you all know, on room air, normal A-to-A gradients, okay, A-to-A gradients are about 5 on room air, like we're sitting here, 5, maybe 5 to 20, okay. On 100% oxygen, it is like a 25 to 65 millimeter of mercury, 100% oxygen. But now, how do we get shunts? So to get shunt, basically what you do is you take your A-to-A gradient and divide it by 20. That's your estimated shunts. Okay. But now, if the baby has A-to-A gradient that is greater than 620, then that should qualify them for ECMO. Now, if you divide 620 by 20, that will come out to be like a shunt of about maybe 31%. That's a lot of shunt. Normal shunt is 5, acceptable is 20 or less. So this is a lot of shunts. The more shunt that you have, the more you are not oxygenating. So having shunt means that you're not oxygenating well. So that would be high shunt, 31% or more. So that should qualify the baby to receive ECMO. The next thing is what they call the oxygen index. Oxygen index. And here is the formula here, okay, for oxygen index. FiO2 times mean airway pressure divided by PaO2. Basically what that means is that how much FiO2 and how much PEEP, because mean airway pressure is basically PEEP, okay, are you using to get this PaO2? How much FiO2 and how much PEEP are you using to get this PaO2? Well, if you're using high FiO2 and high PEEP to get FiO2 that is not reasonable, PaO2 that is not reasonable, that's not good oxygenation, okay? So if you plug in your FiO2 and your PEEP, or mean airway pressure, divided by the PaO2 that is resulting from that blood gas, and you have a number that is greater than 40. If it's greater than 40, then the baby has high oxygen index, okay, and will qualify for ECMO, okay? So oxygen index that is greater than 40 will mean that the baby would need or benefit from ECMO, okay? Any questions? So exclude infant's weight, gestational age less than 35 weeks. We don't want that. Pre-existing conditions like intraventricular hemorrhage that bleeding in their brain, we don't want to do that. And they have been on conventional ventilation for greater than 7 days. We don't want to do ECMO on them either.
Is there a reason why? I'm a bit confused by that one.
Hmm?
Is there a reason why? I'm a bit confused by that one.
For which one? The last one?
Yeah, conventional ventilation.
You know, I really don't know why.
Fair.
I really don't know why. Yeah, but that's what the book says.
Fair.
Yeah, maybe they're used to being on conventional ventilation, and if you put them on that will cause more problem. I really don't know. Complications of ECMO. Bleeding. The action exam, what is the most common complication of ECMO? It will be bleeding. Babies will bleed like crazy because of the heparin. Okay, over a period of time, as you're getting the blood out of their body and running it through heparin so that it doesn't clot outside the body, you overthin their blood. Okay? You overthin their blood. So they are very, very predisposed to bleeding like crazy. Cardiovascular complications secondary to hypo and hypovolemia. Well, hypovolemia means low volume. Hypovolemia means high volume. So when you draw the blood outside the baby's body, their blood pressure may go down. Okay? Their blood pressure will go down. And then if you're returning it back into their body very fast, their blood pressure may go up. Okay, one of the things that affects the blood pressure is the intravascular volume. If you have less intravascular volume, your blood pressure will go down. In other words, you are dehydrated. And then if you have too much of it, your blood pressure can go up if you have a very strong heart. Okay? Anemia can result. Leukopenia means low white count. And thrombocytopenia means low platelets, blood platelets. Okay? And what happens is that the membrane oxygenator will kind of hold on to the cells when the blood goes through it. Filter the cells and hold on to some of their blood cells. So you have low white count, and then you may have low thrombocyte. You may have low platelets. Low platelets will cause you not to clot very well. Okay? And then, of course, if you have leukopenia, your body probably won't be able to fight infection very well. And then some technical complications. Yeah, people are usually trained on this for months and probably years to do this. Not everybody does it. You're going to go a special type of training for a long time to be able to do ECMO. Okay, one ECMO. Usually it's one person doing it, but you have to know everything about that equipment. Okay? Yeah, I'm pretty sure that Presbyterian has one because I've seen it before. Any questions about ECMO? All right, so the next thing is negative pressure ventilation. Negative pressure ventilation. Okay. We are negative pressure ventilators. That's the way we breathe. We breathe according to the amount of negative pressure that we generate. So what we do is when we get ready to breathe, we drop our diaphragm and then the rib cage goes outwards. So by those two things happening, you create negative pressure inside your chest. The amount of pressure inside your chest is now lower than the amount of pressure on the outside of your chest. It's lower than it's subatmospheric. Now, according to law of diffusion, gas will go from area of high concentration to area of low concentration. So it's kind of like this. So what you have here is 760 atmospheric pressure. And then once you drop your diaphragm and expand your rib cage, the pressure here goes to negative below this. Okay, let's say it becomes 750. So it's subatmospheric. By definition, it's negative pressure. Okay? It's negative pressure because it's less than 760. So now gas will begin to go from the outside into your lungs until the pressure here will equilibrate with the pressure out here, and then you stop breathing in. Any questions about that? You stop breathing in. So once the pressure on the outside equilibrates with the pressure inside the lungs, inspiration will end. Okay, but now, negative pressure ventilator kind of does something. Okay? The way we breathe. What negative pressure ventilator does is that they will apply like a negative pressure device around your chest. Okay? Or they'll cover your entire body, only your head will stick out. So once the machine comes on, it applies that negative pressure here to decrease your pleural pressure, okay? So that the pressure inside your lungs will go down. And then that causes you to stop breathing in. At the end of inspiration, the device will quit applying negative pressure. Okay? We have sometimes, we have like, I don't know what I have them here. Have you ever heard about chest compress?
Mm-hmm.
It's a negative pressure device. And then there is iron lung. And then there is another one, that's pneumosuit. These are types of negative pressure ventilators. Basically, that's what they do. They apply negative pressure on your thorax to decrease the pressure inside the lungs. And then you breathe in at the end of inspiration, the device will stop applying negative pressure. Okay? It's used a lot in patients that have neuromuscular disease. Okay? And then it's making a comeback in the neonatal population. Advantages: less risk for barotrauma. Okay? It's negative pressure. What actually causes barotrauma is positive pressure. Okay? Positive pressure will be like the ventilators that we have in there. They are positive pressure ventilators. Okay? Cardiac systems are not compromised. Now, positive pressure ventilators will cause a decrease in cardiac output because they cause a decrease in venous return. Okay, that's why. Positive pressure will prevent venous return to the right heart. Okay? And that's why you have decrease in blood pressure. But negative pressure ventilators can also cause a decrease in cardiac output, but not as much as the positive pressure ventilators. And the reason for that is because of the negative pressure that is applied on the thorax, that can cause blood to pool in the patient's stomach. That's pulling of blood. Okay, so not all the blood is being returned to the right heart. Okay, there's pulling of blood in the patient's stomach. So, but just know that negative pressure ventilator can result in decreased cardiac output, but not as much as the positive pressure ventilators. Okay, any questions about that? So spontaneous breathing, let me just add this to it. Spontaneous breathing enhances cardiac output. Okay? Because anytime you're breathing spontaneously, you're creating negative pressure to breathe. So that negative pressure that you're creating lowers the pressure gradient that is needed for blood to return to the right side of the heart. So a patient who is on pressure support, because they're breathing spontaneously, will have a good blood pressure compared to somebody who is on the ACVC mode. Because the ACVC mode, all the breaths are positive pressure breaths. So that causes more decrease in venous return. But if you have somebody on pressure support where they're breathing spontaneously, they're contracting their diaphragm and stuff, their blood pressure will be very good. Okay? Blood pressure will be higher. Okay? Disadvantages. Poor access to patient. Yeah, the entire patient is encased, usually encased. You just have their head sticking out. So if you want to do something to the patient, any other place you can get to it. You know? Pressure sores around, pressure sores at contact points, you know. Air leaks may cause decreased cardiac output because of the blood pooling. Okay, the patient's stomach. Okay, so what we say is that negative pressure ventilators mimic spontaneous breathing. Okay, they mimic spontaneous breathing because we create negative pressure when we breathe in, and negative pressure ventilators apply negative pressure around the chest to decrease intrapleural pressures. Any questions about that? The next thing is heliox therapy. Heliox therapy is when you mix oxygen and helium together. Oxygen and helium together. Sometimes a patient will have very high airway resistance, like when they have severe asthma, or maybe you just extubated them, they have stridor that is obstructing their airway like crazy, or maybe they have tumor, or maybe they have laryngitis. You know, any kind of airway resistance that is impeding the ability of the patient to oxygenate. Okay, they have high airway resistance and they cannot oxygenate due to that. Oxygen cannot get inside your lungs. So what we do is we mix up oxygen and helium. Now, helium is a lighter gas compared to oxygen. So the helium carries the oxygen around the obstruction into the patient's lungs so that their oxygenation can increase. That's basically what we're doing. Now, helium is an inert gas. It's an inert gas, means that it doesn't react with anything. Okay, it's a neutral gas. Indications to improve gas flow throughout the lungs in the face of severe airway obstruction in such patients as asthmatics. You have croup, that viral infection, post-extubation stridor, laryngitis, okay, tumor, laryngeal tumor, okay, things like that. How do we deliver that? Because if you need to deliver helios therapy, you're gonna push the tank. It's usually the H tank, the big tank of the inside the patient's room. And then you're gonna hook up like a non-rebreather to it. You're gonna have a flow meter there. You hook up the non-rebreather device and then you put it on the patient's face. So we deliver with a non-rebreather mask. Non-rebreather mask. You gotta remember that. That's a very common test question. Okay? Um, Now, just like the oxygen, when somebody is receiving oxygen therapy with the non-rebreather device, the range of flow rate that we set is usually 10 to 15 on the non-rebreather device. Let's say that I started with 10 liters per minute. I'm receiving oxygen therapy. And then during inspiration, if the bag collapses by more than half, do you remember that? The bag collapses by more than half, it's time to increase your flow. Okay? The same thing here. So it's on the test. They're receiving Helios therapy, and the bag is collapsing more than half during inspiration. You increase your flow. The flow rate will still be 10 to 15. That's what you have. Okay, 10 to 15. Another thing is that if a patient is receiving a breathing treatment, let's say Abirua or whatever, Zopinus, you're going to use the Heliox to power the nebulizer, not oxygen, because if you use oxygen, that puts them into distress. Okay, their oxygenation will go down because the oxygen is not going to go in because it's heavier than the Heliox, than the helium. So you're going to hook up the breathing treatment to the tank and then use the Helios to power the nebulizer, give them a breathing treatment to avoid them from being hypoxemic. We can hook it up directly with the ventilator. Patients on the ventilator, you can hook somehow, put the tank in line so that you go through the ventilator socket into the patient's lungs. In fact, there's a specific type of, wait a minute, a specific type of ventilator that is used. I can't think about the name now. Okay. I can't think about it now. But if you have that ventilator and they want to use it, then you bring that ventilator. Just like we have one for nitric oxide.
So we did do that, or we have done that at UNM.
You have done it?
It was just on a 980, so I don't know.
It was on what?
It was on a 980.
980? Oh, yeah. Yeah, you can hook it up to regular ventilator, but I think there's a special type of ventilator that can do that. Huh?
The Knox box.
That's nitric oxide.
I forgot, it's been a long time ago. Yeah, but somehow you can put it online, just like Brian said, you know, it's online. But I know if there's one called Inovent. But this one here is for nitric oxide. Okay. But the other one I don't quite remember. Okay. But that's fine. Just know that you can hook it up, with the ventilator. Okay. Mixing concentrations. Well, we have 3 concentrations. We have 80-20 mixture. So that's the standard mixture. So on the exam, if they ask you what is a normal Heliox therapy, you say 80-20. Okay. What is standard Helios therapy? You say 80-20 mixture. So in that mixture, you have 80% helium, and then you have 20% oxygen. Okay, so we have 70-30. In the mixture, you have 70% helium and 20% oxygen, 30% oxygen. And then you have the 60-40. Usually for babies, they use the 60-40. The more oxygen that you have in the mixture, the less the effect of the therapy. Okay? So that's why 80-20 is the standard mixture. Okay, so what we use to deliver this is oxygen flow meter. We use the oxygen flow meter to deliver Helios therapy. So what happens is that because The helium in the mixture is a lighter gas than oxygen. When you set a specific flow rate on the flow meter, okay, the actual flow going to the patient is more than what you set. Now, let's say that I said, that's my flow meter, I said 10 liters per minute of helium on the oxygen flow meter. What the patient is receiving is actually more than that because of the helium in the mixture being very light. Okay? So we have correction factor for each mixture. Like if my patient is receiving the 80-20 and I have them set on 10 liters per minute, the actual flow, we'll call it the actual flow going to the patient. The actual flow going to the patient is about 1.8 liters per minute more. It's more, like now, you know, so I have the flow meter set at 10. What is actually going to the patient is 18 liters per minute. So 10 times that. You have to remember that. Okay? If I'm doing the 70-30, what is going to the patient is 1.6 liters per minute more flow. So if I have my patient on 10 liters per minute, if I set it on 10 liters per minute, what the patient is actually receiving is 16 liters per minute. If I'm doing the 60-40, it is 1.4 liters per minute more. So they usually have a question like that on the TMC test. There's a formula for it. It goes like actual flow, what the patient is actually receiving, equals correction factor times liter flow. That's a formula you will never want to forget your entire life, as long as you're a respiratory therapist. So now, that can go well. A patient is receiving 80-20 heliax. Okay? The patient has a liter flow of 10 set on the flow meter. What is the actual flow going to the patient? So remember this formula. There you go. Well, I'm doing 80-20, and the correction factor is 1.8 times the liter flow. So my patient is actually receiving 18 liters per minute. It's there. The reason it's always on the test is because as a respiratory therapist, you're going to have to do this someday, and you have to know what you're doing. That's why it's always on the MDLC test. Okay, so this is one point that you don't want to miss on the exam. Or maybe they can go, well, they are on 10 liters per minute, and they're receiving 70-30 helios therapy. What is the actual flow? Then you're going to say, well, the correction factor for this is 1.6 times the liter flow, which in this case is 10. So they're actually receiving 16 liters per minute. Well, if they really want to be funny about this, they can go, well, the actual flow, they can give you the actual flow. They can say, well, the actual flow is 18 liters per minute, and the patient is on 80-20 helios therapy. What is the flow meter set on? They go, well, actual flow is 18, and they're receiving 70-30. No, they're receiving 80-20, So the factor is 1.8 times the liter flow, like that. So all you have to do in this case is you divide 18 by 1.8, and you're back to that 10 liters per minute. So they can ask it to you either way. They will probably give you the concentration of the Helios therapy, give you the liter flow, and ask you to calculate the actual flow. Or maybe they will give you the actual flow and tell you the concentration and actual, what is the flow meter set on. Any questions about that? Outcomes of Helios therapy increases respiratory flow. Okay, it can cause you to exhale out, reduces obstruction. So you can exhale out more air. It decreases work of breathing. Okay, because you're struggling to breathe due to the obstruction. Yeah, so we do that. Decreases PIP, okay, and CO2 for converted patients. Okay. The lower the obstruction, the lower the PIP. And then we have inhaled nitric oxide. Inhaled nitric oxide. Nitric oxide is produced naturally in the endothelial cells of the body. So we make nitric oxide. Nitric oxide is a vasodilator. Anytime you have inflammatory process inside your lungs, your body will respond by making more nitric oxide. If you don't have a lot of inflammation, so your body doesn't make a lot of nitric oxide. So there's one question that I remember on the body exam about that. This is an asthmatic patient, okay, that is receiving corticosteroid. Okay, steroid, like Flovent. But their exhaled nitric oxide, the amount of nitric oxide that they're exhaling out, is low. It's very low. But they have inflammation inside their lungs as a result of asthma. And they're using Flovent, like a steroid. But when they exhale, their exhaled nitric oxide is very low. What is the reason for that? Well, the reason for that is because the corticosteroid is for inflammation as well. So it is already decreasing the inflammation inside the lungs. So the patient's lungs do not have any reason to make a lot of nitric oxide. Therefore, their nitric oxide level is very low. Okay, so I remember that question. So we'll be on the lookout for that type of question. Another thing I want you to remember nitric oxide for is persistent pulmonary hypertension of the newborn. It is a vasodilator. It will vasodilate the pulmonary blood vessels, therefore increasing blood flow into the lungs. So it's very good for that. Indications indicating when the body is unable to produce this due to illness or injury. You're sick with something, the body cannot make enough to keep up with your sickness. Okay? And for instance, if people didn't have diabetes, maybe the amount of insulin in their body would do. But because they do, well, it's not enough. Conditions such as pulmonary hypertension of the newborn, RDS, meconium aspiration syndrome, pneumonia, sepsis, and diaphragmatic hernia respond well to nitric oxide. Normal dose of nitric oxide is 20 to 80 parts per million. 20 to 80 parts per million. therapeutic outcomes, patient must be monitored for methemoglobinemia. Well, methemoglobinemia will give you methemoglobin. That's dysfunctional hemoglobin. Now, we talked about two of them. We say that carboxyhemoglobin is one, and then we have the methemoglobin. These are dysfunctional hemoglobin. They cannot carry oxygen. If you have too much of any of these two here, your oxygen carrying capacity to the tissues will decrease. Okay, now what causes methemoglobin is chemicals. Drugs are chemicals. Nitric oxide is chemical, made by the body. So too much nitric oxide can cause you to have a lot of methemoglobin. That's what we mean by methemoglobinemia. Usually the result of that is that you're going to have hypoxia because your hemoglobin will not be carrying a lot of oxygen down to the tissues. The next complication that may result from that is formation of nitrogen dioxide. Nitrogen dioxide. The nitric oxide mixes with water inside your lungs and forms nitrogen dioxide. And that is a chemical that is very, very irritating in the lungs. Very, very irritating, nitrogen dioxide. And then it can also, I don't have that one here, it can also cause, nitric oxide can also cause pulmonary edema. It can cause pulmonary edema. So nitrogen dioxide should not exceed 5 parts per million. The goal is less than 2, okay? So we have to keep our eyes on that when we're doing nitric oxide therapy. High level of nitrogen dioxide can cause pulmonary edema, injury, or death. Weaning of nitrogen dioxide should be done gradually. Now, because the body makes that, just like the steroid. When you get ready to wean your patient from steroid, you wean it gradually so that the body can resume making its own steroid. The same thing with nitric oxide. If you want to wean it, you wean it gradually and you wean it very low to like 2 parts per million before you take the patient off of it. Now, if you just take it off, you are going to cause what they call rebound effect. Now, a rebound effect is like causing the opposite of what you're trying to treat. For instance, in this case here, we're trying to vasodilate. So a rebound effect will be vasoconstriction. Vasoconstriction. Okay, people, when you take people have their steroid very quickly, they're going to have a rebound effect. They have mood changes, they're going to get angry, they're not going to feel well. Okay? It's sort of like an addiction. You smoke a lot, and then you've gone for 1 week without smoking. You're not going to feel well. Okay? Any questions about nitric oxide?
Can you say again what the nitrogen dioxide is? Is
Huh?
it liquid? Nitrogen dioxide?
Yeah, it's a substance.
Okay.
Or an element, if you want to say a compound. It's actually a compound because it has 2 elements in it, nitrogen and oxygen. It's a chemical compound.
But you said it causes,
It causes irritation inside the lungs.
thank you.
Yeah, because if you're receiving the nitric oxide, then it's like water combines with the nitric oxide, then you form the nitrogen dioxide. We can balance the equation here. You remember chemistry? We can balance the equation. Yeah, you know how to balance the equation? Okay, we have one nitrogen here, one nitrogen here, two oxygen here. So I'm gonna put, if I put, so let me see, if I can remember how to do it. If I put two here, then that gives me two oxygen.
You've already got two oxygen, right?
Huh?
You've already
Yeah,
got
you
two
already have
oxygen.
Say that again?
You've already got two oxygen on that side.
Oh, yeah, okay, hold on, that's right. That's oxygen, that's two there. Nitrogen one, nitrogen one. That's right. Yeah.
You need two
Oh.
helium on the other side.
It's been a long time.
Huh?
Hydrogen.
I meant that.
Helium.
I didn't have to
Helium,
think
that would be
about
interesting.
several times. Because actually I teach chemistry online, but I teach basic chemistry. For the bachelor's degree program. Any questions about this? All right, so it's break time.